Good evening, everyone. I welcome you all for this advanced pediatric neurology talk. And today we have Dr. Margi Desai, who is an eminent name in terms of clinical neurophysiology. And she's at SRCC Children's Hospital, Mumbai, and Dr. Udani will be briefing her out. When it comes to the topic, it's very, very interesting, I should say, and much undwelled as well, because most of us, due to technical difficulties or not having enough infrastructure, we always underutilized evoked potentials. So I guess, it was really very, very tempting to keep her here, and we cannot find, a better moderator than Dr. Rajesh Udani for this, because I know I have been mentored by him and how much he used to really push us for all this. So Sneha, please share the slide for Dr. Udani. I know none of us really needs all this. We all know him very well when it comes to qualifications and positions and his publications, etc. Most of us, many of us are mentored by him and have learned a lot from him. So, sir, I would like to hand over the proceedings to you. I guess we would like to hear most from Dr. Margi Desai, so not coming in between. So over to you to introduce the speaker.
Yeah. Thank you very much, Rachna, for those very kind words. I think it gives me great pleasure to welcome Margi. She's been a friend and colleague for many years. She, in fact, worked in Hinduja for a bit at one time. And I was really, it's an unusual qualification. That a pediatrician by basic training went into clinical neurophysiology as a specialty and has really excelled in the field. There are very few clinical neurophysiologists in the city, in fact, in the country, who do purely neurophysiology. And I think Margi is very much at the very top of this rare field. She presently is a consultant at Jaslok Hospital as well as the SRCC. And after, she has passed her medical college from Ahmedabad, from BJ Medical College. And as you can see, lots of gold medals, etc. She has trained in neurophysiology, if I remember right, at Jaslok Hospital and also abroad. And I do all my basic, and whenever it's advanced, something I want an opinion on evoked potentials or on EMGs or whatever, I always go to her because I think she's one of the best in the field. So Margi, I hope you give us a talk on evoked potentials. We used to use a lot of evoked potentials in the past, but MRI has sort of reduced that, but still it's has its place very much, and needs to understand neurophysiology better when you use your potentials. Thank you so much. Please, Margi.
Thank you, Dr. Udani and Dr. Rachna, for those kind words. I have been asked to talk on applications of evoked potentials. So my first talk is going to be on SSEPs. At the end of the talk, there are 4 or 5 questions which we'll talk about, question and answers. And after that, we can take questions on SSEP, and thereafter I'll give a talk on BEPs and BAEPs, so that there's a break between the SSEPs and the other evoked potentials. Is that all right, Dr. Udani?
Perfect.
Yeah, okay. Should I share my screen?
Yeah.
Can you see the screen and hear me?
Yes.
Okay. Yes, clearly.
Okay. I'm going to talk on SSEPs in children. So what are evoked potentials? An evoked potential is an electrical potential recorded from the scalp. However, it is generated in the cortex following presentation of a stimulus to the sense organ. So now we know that there are many types of sense organs. Therefore, evoked potentials can be sensory, motor, or event related. Today, we are going to talk about the sensory evoked potentials, the first one being the somatosensory evoked potential. Subsequently, we will talk of the other sense organs, hearing and vision. Somatosensory evoked potentials are brain and spinal cord responses elicited by sensory stimuli. The clinically used SSEPs are usually elicited by electrical stimulation of a peripheral nerve. The common sites are median nerve stimulation at wrist and tibial nerve stimulation at ankle. As we know, both of them are mixed nerves. However, other stimuli such as pain and touch can also yield SSEPs. For example, earlier we used to do dermatomal SSEPs, where we just give a slight current to the skin. For example, if you are stimulating the L4 dermatome over the thigh, you will elicit an L4 dermatomal SSEP. So various modalities can be used to evoke potentials. SSEPs consist of a series of positive negative potentials as the impulse travels along the somatosensory pathway, which are the large diameter posterior tracts in the spinal cords. Knowing the anatomical origin of the SSEP components helps in localization of lesions along this pathway. So what is the pathophysiology? In a mixed peripheral nerves, both motor and sensory fibers are activated when you give a electrical stimulus to the mixed nerve. Depolarization of the motor fiber induces muscle fiber depolarization and therefore causes twitch. For example, when you stimulate the median nerve at the wrist, if you give a slight current, you will elicit a motor twitch in the abductor pollicis brevis muscle. This is because of the depolarization of the motor fibers. And there will be antidromic conduction of the impulse towards the spinal cord. The antidromic motor impulses, however, are extinguished at the level of the anterior horn cell, and they do not propagate beyond this point, and that's why you don't get a motor evoked potential. The reason motor impulses are not conveyed to the central motor pathway is that the neurochemical transmission is only one way, that is unilateral, from the suprasegmental axon to the anterior horn cell dendrites. It is not the other way around, so it cannot propagate from the anterior horn cell proximally to the pyramidal tract. However, it's different for sensory fibers. The activated sensory fibers propagate orthodromically along the peripheral nerve to the spinal cord, and following 3 synapses, they terminate in the sensory homunculus in the contralateral sensory cortex, in the cerebral cortex. So now which sensory fibers are activated when the designated impulse is given, and which pathway in the spinal cord conveys these action potentials to the cerebral cortex? Let's look at that. So using the Lloyd's classification for classifying the nerve fibers, it has been found that in the cat, delivery of 1.5 to twice the threshold for activation of the 1A fibers exclusively activates the type 1A fibers. And at stimulus intensity is 2 times greater than the threshold value, group 2 fibers are also excited. Now we know that type 1A and type 2 are the large myelinated fibers. So for example, when you get a minimal toe or a thumb twitch by giving electrical stimulus either to the median nerve or the tibial nerve, this will preferentially activate the group 1 and the group 2 nerve fibers in humans. The small group fibers, that is the unmyelinated fibers, the A delta and type 4 fibers, require higher current intensities and therefore they are not activated. Now, once these nerve fibers are activated by our electrical stimulus, the action potential travels orthodromically, or you could call it centripetally, towards the spinal cord through the dorsal cord and then the dorsal tracts of the spinal cord. So this is how the SSEP is generated. And we have also learned why in a mixed nerve, the motor fibers do not elicit a response. What are the indications of SSEP? We all know that children with Friedreich's ataxia, A beta lipoproteinemia have abnormal SSEPs. So any child with ataxia needs to undergo SSEP. Children with gait disorders, postural instability also warrant an SSEP. SSEPs are also useful when you suspect spinal cord demyelination, either due to a leukodystrophy or due to acquired demyelination such as multiple sclerosis. SSEPs are particularly helpful in identifying asymptomatic demyelination in the spinal cord in children with MS. They help in assessment of posterior column function in children with neural tube defects, like children with meningomyelocele. SSEPs are also indicated in patients with myelopathy, myeloneuropathies. For example, myeloneuropathy due to vitamin B12 deficiency or HIV myelopathy, and in children with transverse myelitis. Ischemia, tumors, and infection of the spinal cord also can be evaluated with the help of SSEP. Lastly, SSEPs are used for prognostication in hypoxic brain damage. They are more useful than brainstem auditor evoked potential in assessment of and prognostication in hypoxic brain damage. So what information do SSEPs provide? They provide information on posterior column function or the dorsal columns of the spinal cord, and they help in distinguishing between peripheral and central conduction delay. So let's look at the technique of SSEP. Median or ulnar nerve either can be stimulated at the wrist. At the ankle, the tibial nerve is stimulated. In order to do the test, the child's eyes should be shut, mouth and jaw should be relaxed, preferably they should not swallow. Therefore, in children, we sedate them so that they do not move and their eyes remain shut. The electrical impulse is a square wave pulse. Its duration is usually 0.1 to 0.3 millisecond. The frequency of stimulation is 1.5 to 3 hertz, so it should be slow. You should never give a frequency greater than 5 hertz for eliciting SSEPs. And how much stimulus means how much current will you give? It should be given in such a way that it produces a slight muscle twitch in the APB. As you can see here, this is the resting muscle, and here you give a current so that there is a slight twitch and subtle abduction of the thumb. This will elicit the type 1 and the type 2 fibers. How is the SSEP recorded? The recording site. 2-channel recording or 1-channel recording can be carried out in children. One site of recording is the ipsilateral Erb's point. And the second site of recording is on the contralateral scalp, that is overlying the parietal cortex. So this distance is, find CZ, goes 2 centimeters posterior to CZ and 7 centimeters on the lateral side, contralateral to the side you are stimulating. So in case of right median nerve stimulation, the active electrode will be over C3, and in case of left, it will be over C4. This corresponds to the sensory homunculus for the hand. As you can see here, this is the midline and this is the parietal prominence where you will apply the active electrode. The reference electrode is applied over FZ. So when you stimulate the nerve, this is the potential you will get at Erb's point. It is known as N9 because it arrives at a latency of 9 milliseconds. And the potential that you get, the negative peak you get at 20 milliseconds is known as N20. However, in children, the arm of the length varies. So the latency is often not 20. It can be as low as 14 to 15 milliseconds, depending on the age of the child and the length of his arm. So what is the anatomical pathway of the SSEPs? We have discussed this earlier. First, an electrical stimulus is given to the mixed nerve, either at the wrist or the ankle. This stimulates so many, the Pacinian corpuscles, the Golgi tendon organs, and elicits a twitch. The impulse is conducted through these fibers and it reaches the dorsal root ganglia. So this is the first synapse at the level of the dorsal root ganglion. Subsequently, the impulse travels in the posterior column of the spinal cord ipsilaterally, either the gracile or the cuneate tracts. In case of median nerve stimulation, it reaches the ipsilateral cuneate nucleus in the medulla. Thereafter, it crosses the midline and it reaches the ventroposterolateral, that is the VPL nucleus in the contralateral thalamus. So this is the second order neuron, the second synapse. After this, the impulse continues along the spinothalamic tract and goes to the primary sensory somatosensory cortex in the parietal lobe. So this is the third order neuron. So you can see the crossing over occurs after the midbrain. This is a recording of a single channel median SSEP in a child. What we see here is the N20 latency and the P23. The SSEPs that you get are usually elicited after averaging. That is, you can't give one stimulus and get a response. You have to average at least till 100 and 200 stimuli so that the noise is removed, the response becomes clearly visible, and thereafter you can smoothen the response, which is available in all machines. So now how do we know whether the SSEP is accurate or not? In order to know that, you must see that the response is reproducible. Therefore, for each SSEP that you perform, 2 runs must be taken in order to show reproducibility of the response. So this is the safe side response, run 1 and run 2. And if I were to drag this above this, you can see that both responses are reproducible. So reproducibility of an SSCP is a must. In case of lower limbs, the tibial nerve is stimulated. Usually, we only stimulate the tibial nerve at the ankle and we record over the cortex. So the active electrode is 2 centimeters posterior to the CZ in midline, and the reference electrode is FZ. Usually, we do not put the lumbar electrode. However, if you want, you can. This is placed at the L2 spine level, and the response you elicit is known as N20. Now, the reason we put the active electrode 2 centimeters posterior to CZ is this is the area which subserves the foot. So this is the sensory homunculus for the foot. Because this lies in the midline, we don't need to put 2 individual electrodes for lower limb SSCP. In case of hands, the sensory homunculus is over here. Therefore, we need to put over C4 and C3. However, in case of lower limb, a single electrode is useful for recording SSCPs from both lower limbs. So this will be the active and this will be the reference. In case of one channel recording, this is what you will elicit: a first positive response followed by a negative response. And if a 2-channel recording is carried out, the lumbar potential, which is elicited by putting the active electrode at L2 spine, this will be the first response and this is the second response. So what are the factors affecting SSCP? SSCP latency varies according to the age of the child because they are dependent on the length of the arm. Latencies are shorter in children. There is no effect of sedative drugs on SSCP. So pedicloryl, diazepam, and melatonin can be used to sedate the child. However, anesthetic drugs such as propofol and barbiturates can reduce the amplitude of cortical SSCPs. Etomidate can be used because it facilitates the amplitude of SSCPs. However, this is only used in intraoperative monitoring. Peripheral neuropathies in children, for example, slowing of motor conduction velocities in children of HMSN, can also prolong latencies of all peaks in SSCPs. So when you have a peripheral conduction delay, one can calculate the central conduction time. Now, as we discussed earlier, in the upper extremity, the first potential is N9 at Earth's point. I'm sorry, this is a mistake. And then there is a potential at, so you could do N20 latency minus N9 latency. So the N9 latency is the peripheral conduction. Once you subtract that from N20, all you get is the central conduction time. So even in children with peripheral delay, the central conduction time can be calculated. And if that is normal, you know that there is no problem in the central conduction. And similarly, the central conduction time can be calculated from the lower limbs. P40 minus the N20 potential. So what are the criteria for abnormalities of SSCP? First is delayed latency, delayed N20 latency or delayed P40 latency in case of lower limbs, or an absent cortical response. The third, but the least important abnormality is amplitude abnormality. When the interside amplitude difference is greater than 50%, it is considered abnormal in adults. However, I find that it is often not a reliable finding in children. So I do not take this into consideration usually when I do SSCPs in children. I only look at the latency, whether it is delayed or whether it's absent. Delayed SSCP latencies can be found in Friedreich's ataxia, demyelinating disorders of the spinal cord such as leukodystrophy or multiple sclerosis, and in myeloradiculopathies. What about SSCPs in large unilateral hemispheric lesions? Here, tibial SSCPs are not useful, but median SSCPs can show asymmetric delay or asymmetric prolongation, which is contralateral to the side of the hemispheric lesion. In case of thalamic lesions, if the lesion is slow growing, if it's a slow growing tumor, the SSCP latency is normal. If it is a mass lesion compressing the thalamus, there is loss of median and the tibial SSCP. So it depends on how rapidly the tumor grows and how large it is. Let's look at one or two cases. This is a 10-month-old boy who had a small dimple over the lower back. He had normal motor development, no weakness in the lower limbs, and preserved knee and ankle jerks bilaterally. This was his tibial SSCP. Now, if you see, this is the tibial SSCP from the left lower limb. The P40 latency on the left side is 40 milliseconds. Now, his age is 10 months. So the normal value of P40 at that age is between 24 to 26 milliseconds, and 28 milliseconds is the upper limit of normal. On the right side, the tibial SSCP latency is 24 milliseconds, which is normal. So the interpretation here is that there is unilaterally prolonged left tibial SSCP suggestive of unilateral posterior column dysfunction. His MRI showed tethered cord and spinal vertebral defects. So here SSCP was important in identifying an abnormality. So one must remember that when there is a cauda equina lesion, a meningomyelocele, which is essentially a mid-thoracic cord lesion, the tibial SSCPs may be abnormally delayed or absent. However, median SSCP should always be normal. So in all children with meningomyelocele, if you find absent tibial SSCPs from the lower limb, you must perform the one median SSCP from the upper limb and ensure that it is normal. If the median SSCP is also normal in a child with meningomyelocele, you must do a cervical spine MRI to make sure there is no vertebral defect at the cervical level as well. In case of an isolated cauda equina or mid-thoracic lesion, you must get a normal median SSCP. Let's look at another case. This is a 7-day-old female child brought with the following presentation. So she was brought like this. This was her MRI at the age of 7 days. Diastematomyelia, tethered cord, intramedullary arachnoid cyst at L1, L2, and diastematomyelia at L2, L3 level. The same finding was seen on MRI of the lumbosacral spine. An oval hyperintense lesion seen in the cord at L1, L2 level. Cord then immediately splits into two equal hemichords. At this time, she had no weakness in the lower limbs and she had normal deep tendon reflexes. So the parents decided not to do anything about the tuft of the hair despite knowing the abnormal MRI. The girl had normal motor development until the age of 6 years. At 6 years of age, she again went to the doctor because there was recent onset of stool incontinence and occasional urinary incontinence. Even at this age, she did not have weakness in the lower limbs. However, parents were concerned about incontinence, so they went back to the doctor. The repeat tibial, this was the first time we did her tibial SSCPs. Now, at this, she was 6 years of age and her P40 latency was 41 millisecond in the right lower limb and 41 in the left lower limb as well. The upper limit of normal for this age group is 32 to 33 milliseconds. So the interpretation is that now there were grossly prolonged P40 latencies bilaterally. This would suggest significant damage to the posterior column in the spinal cord. And this was her repeat MRI at the age of 6 years. A narrow spina bifida was detected at L4, L5 and also from S2 to S5 segments and hydromyelia in the spinal cord at L2, L3 level, causing thinning of the cord parenchyma. Subsequently, she underwent surgery at the age of 6 years. The other role of SSCP is in prognostication. Absent median SSCPs, that is absent N20 response in comatose patients due to anoxic brain damage is a very poor prognostic sign and it has 95% sensitivity. So the sensitivity of median SSCP in prognostication is much higher than that of BAEP in anoxic brain damage. Bilateral absence of N20 in comatose patients due to head injury also suggests poor outcome, often a prognostication that it will lead to persistent vegetative state. Median SSCP will be absent bilaterally in brain death. The other way of prognosticating is doing tibial SSCPs in children with meningomyelocele. Unilaterally or bilaterally absent tibial SSCP suggests significant posterior column dysfunction and cord damage. Lastly, looking at the amplitude of SSCPs. Up until now, we were discussing latencies of SSCPs and presence or abolition of SSCPs. There are some conditions where you get giant amplitudes of SSCPs. Now, when we say giant amplitude, we refer to the median SSCPs. If the amplitude of median SSCP, that is the N20 to P24 amplitude, that is peak to peak amplitude, is greater than 10 microvolt, it is known as a giant SSCP. This is recorded in patients with cortical myoconus, that is in children with SSCP, SSPE, and children with progressive myoclonic epilepsies. So as you can see in this picture, N20 to P24 amplitude. Now this one division is 5 microvolt. So this is 5 microvolt plus 5 microvolt, 10 microvolt plus this. So it's around 12 to 13 microvolt in amplitude. So this is a giant SSCP recorded from a child with SSPE. Giant SSCPs can also be seen in patients who have post-anoxic myoclonus. There are some limitations of SSP. All patients with myelopathy may not have abnormal SSCPs, and they are not useful for central motor pathway disorders. So if a child has a corticospinal tract lesion, SSCPs will be normal. Also, they may not be abnormal in disorders presenting with spasticity. So people often send children with HSP, hereditary spastic paraparesis, for SSCPs. However, SSCPs are always normal in children with HSP. Should we take some review questions?
Yes, sure. Sure.
Why not? Yes.
So this is a chapter on SSCPs by Berger and Bloom. So the question is that SSCP testing will show abnormalities if which of the following tracts is damaged. These are the 4 options: gracile, corticospinal, spinothalamic, and lateral lemniscus. Does the audience have access to the audio?
Somebody's
No,
answered.
Yeah.
Everybody's answered A.
Yeah, I can see the chat.
You can see. Yeah. Yeah.
Okay, any more?
So we can see.
So everyone has answered correctly so far?
Yes. Yes. So A. 3 people. Yeah.
So the correct answer is A. As I discussed, the cunate tract transmits impulses from the median SSCP and the gracile tract for the tibial SSCP. Corticospinal tract cannot be assessed by our test. It can be assessed only through MEP, motor evoked potentials. And lateral lemniscus cannot be assessed, right? BAEP assesses the lateral lemniscus. Next question, SSCPs in children typically demonstrate which of the following characteristics? Normal median SSCP latencies by the age 5, most marked change in latency after age 4, the presence of N20 in all term neonates, subcortical potentials in all term neonates. So this is a little tricky.
I don't see.
Is there any reply on the chat?
Yeah,
C.
there is one. C.
B.
Yeah. Vibhu Upadhyay.
Somebody has said B.
B. Yes.
B, C.
C. B, C.
Okay. So B is most marked change in latency after age 4 and C is presence of N20 in all term neonates. C is not correct. Let me explain this to you. Okay, the correct answer is D. So N20 is often not seen in term neonates. So C is not the correct answer. Subcortical potentials are seen in, should be seen in all term neonates. That is correct. And median SSCPs reach normal values after tibial SSCP, typically at the age of 6 to 8 years. So those who had written this B, most marked change in latency after age 4 years is applicable to only tibial SSEPs and not median SSEPs. Therefore, we can't take it as a correct answer. Both will be seen at adult values, typically at the age between 6 and 8. And the most rapid change in conduction speed occurs in early infancy, not after the age of 4 years. So the correct answer is B. Next question. A term neonate with brachial plexus injury could have all of the following on median SSEP testing except absent N20, absent P14, absent N9, prolonged P14. So now we know where is N9 generated. It's generated at the level of brachial plexus, Erb's point. And N20 is the cortical response from the contralateral somatosensory cortex.
So we can see A, C, A, 3 answers, right?
A is right.
And A, C, A.
Why
B
should C,
as well?
C be there? The question is accept. A term neonate with brachial plexus injury could have all the following on median SSEP except he could always have absent N9 because it is generated at the level of Erb's point. So that cannot be the answer, right? Correct answer is B. Brachial plexus injury in neonates and adults can cause absent N9 with equally delayed but present subcortical potentials. Adults should also have equally delayed cortical potential. See, the moment the peripheral potential is delayed, the cortical potentials will be proportionately delayed. But P14 cannot be absent because it is a subcortical potential. So that is the correct answer. And neonates may not have N20 responses present until 2 months of age. So we had discussed that earlier also. In median SSEPs, neonates may not have well-formed N20 response until the age of 2 months. So with this, we end this session and we can take some questions.
Maybe questions we can take at the end for all subsections, maybe.
Okay.
Dr. Naveen, is that okay? Because I don't see any questions right now. And maybe we can take for everything, all subsections.
Could I ask a question?
Yeah, sure.
Yeah, very, very interesting talk, and the whole basics of SSEP you really well explained. I want to find out in this day of imaging, suppose, what would be the indications according to you? I mean, you mentioned, for example, demyelination with imaging. Would you, the McDonald's criteria and this and that, you need to do SSEPs, or you think, what are the specific indications with the MRI will not help you? So where you need to, what do you think?
You mean for acquired demyelination or
No,
you
for any of the, so you were given lots of indications. So which ones do you think will be absolutely essential? Obviously the ones which
I think
need to be done.
suspected demyelination.
I see. So in the sense,
And pre-operative in children with meningomyelocele.
right, that would be an interesting one, because, and can you monitor these kids? Because that's what I try to do, because when you have patients who are absolutely normal and they're not ready for surgery, we don't wait for the deficit. So once in every year or every 6 months you do the SSEPs, it could help.
That was exactly the reason I presented the first case. She came
correct.
at 6 months. She decided not to do anything, so no test was done. And then she had severe incontinence, and then everything was abnormal,
right.
SSEPs and all.
Exactly.
So
by that time it's a bit late.
Yeah. So a large number of children with meningomyelocele who come to me for SSEPs are clinically normal. They have normal power in the lower limbs, but sometimes there is unilateral absence of tibial SSCP or bilateral delay of tibial SSCP. That is a sign of significant damage to the posterior column, and they should undergo some surgical intervention, before they lose motor power in the legs.
So
Does it
there are a
help
few
also?
questions.
Now
Sorry.
that is the
Sorry.
problem. A large number of those children don't come back to me post-op.
Correct.
So I'm telling the surgeons that you should send them, if the pre-op SSCP was abnormal, you must send them to me post-op. So we are trying to see if we can mount a study for this.
So there are a few questions on the chat box, as we can see. Use of SSCP in scoliosis surgery. This is what is the first question.
So I think most children who undergo scoliosis surgery, at least in Mumbai, undergo intraoperative monitoring.
Okay. And there is one question which says MRI negative posterolateral syndrome.
I didn't understand that question.
Yeah, it's, and then intraoperative monitoring. Yes, this is.
Yeah, so
Yeah.
that is not the topic of my talk, but yes, intraoperative SCP and MEP monitoring will be a talk by itself.
Yeah. That's it. That's
Okay.
it. I guess
Yeah.
we can move on to the next.
Thank you.
Thank you.
Can you see the screen?
Yes.
Yeah.
So my next topic is application of visual evoked potentials in children and in clinical practice. We already discussed the classification of evoked potentials. We'll now look at visual evoked potentials, which are electrical potential differences recorded from the scalp in response to visual stimuli. The VEP assesses the integrity of the visual pathway from the optic nerve through the optic chiasma up to the optic radiation and to the occipital cortex. So this is the entire pathway of the VEP. These are transient VEPs because they are recorded to stimuli which are repeated at low rates, 1 to 2 Hertz. The generators of VEP. Visual evoked response is usually a mass response of cortical and possibly subcortical visual areas. And this is the pathway of the visual evoked potential. I'll discuss it in detail. The most important aspect of the pattern VEP is that a functional striate cortex, which is located in the occipital lobe, is required to generate a VEP, whether it's a flash VEP or a pattern VEP. So this is the area of the striate cortex in the occipital lobe. What are the types of VEPs? You all know that pattern reversal, that is a checkerboard pattern reversal, can be used in children who are older, who can sit on a chair and fixate vision. So this is a cathode ray tube monitor on which there is this checkerboard pattern. The size of the checks could be 12 by 16 or 6 by 8. The black and white checks reverse when the stimulus is started, and this frequency is 1 to 2 Hertz. If a child cannot sit and fixate vision on this central red dot, then a flash VEP can be performed. In case of both types of VEPs, the electrode placement remains the same. The active electrode is placed 4 centimeters above the inion, that is over OZ. This corresponds to the tip of the calcarine fissure in the occipital cortex. So let's look at that picture again. Here. The calcarine fissure. Because it is in the midline, only one electrode is required over the OZ in spite of testing each eye separately. So you don't need to apply a contralateral electrode on this side or this side. If you are doing a full field pattern VEP. If you are doing a hemi-field pattern VEP, then you might need to apply an electrode on the contralateral occipital lobe. One recording is used for studying both occipital lobes, and the reference electrode is at FZ. So this is the active electrode and this is the reference electrode. And a ground electrode can be placed here or over the forehead. The testing protocol, the recording is always monoocular. The other eye should be patched. The room should be dark. If you are doing a pattern VEP, then the patient should be seated at a distance of 1 meter from the cathode ray tube. If the child has a refractory error, it should be corrected. The child should fix gaze at the center of the monitor and fixate his gaze on the red dot, and pupils should not be dilated when doing pattern VEP. The pattern VEP gives information primarily on the central vision, that is the fovea. The fovea comprises of the optic nerve head and the macula. Now, a large region of the occipital cortex near our recording electrode OZ is devoted to macular projections. Therefore, you get a good idea of the foveal function by doing pattern VER. What are the waveforms in the pattern VEP? So the configuration is a negative response followed by a positive response and a negative response. The latencies give them the nomenclature. So N arrives at 75 milliseconds, therefore called N75. The positive wave usually arrives at a latency of 100 milliseconds, hence called P100. And thereafter, the negative response arriving at 135 milliseconds, known as N135. The most important wave for us is the P100, the latency of this wave. In our lab, the normal range of P100 is 110 to 112 milliseconds. If it's prolonged beyond that, we would call it abnormal. An inter-eye P100 latency difference of greater than 5 milliseconds is considered abnormal. And 10 millisecond inter-eye difference in P100 latency is grossly abnormal. These are the normal values of pattern VEP. As you can see, there is a slight difference in our values compared to those shared by Mishra and Kalita in their textbook. We take an inter-eye P100 latency difference of 4 or more as abnormal, and they take about 2 milliseconds or more as abnormal. The lower limit of normal range for the amplitude is roughly same for both of us, about 7 microvolt. The report of pattern VEP looks like this. I'm sharing this because many people are not aware of what to see and how to interpret a pattern VEP report. Usually the comment will say that to pattern reversal stimuli, visual AOC responses are normally latencies from both eyes and amplitudes are also within the normal range. Normal pattern VER findings from both eyes, and there is no evidence of optic nerve demyelination. So what are the limitations of pattern VER? First of all, voluntary inattention by the child, that is defocusing. That can alter the pattern VER latency and lead to a false positive prolonged P100 latency. Therefore, it goes without saying that patient's cooperation is required during pattern VEP. If you are not sure that whether the child is focusing properly on the red dot, then you should not report it as abnormal, and you should do a repeat test when the child is more alert and cooperative. The clinical utility of pattern VEP. It is useful in demyelinating disorders where the P100 latency is prolonged, but the amplitude remains normal. As opposed to that in axon loss neuropathy, which can be due to ischemic optic neuropathy, tumors, there is reduction in the VEP amplitude and not so much delay in latency. So if you see this paper, in case of axonal optic neuropathy, the latency prolongation was usually never more than 10 milliseconds. The most important abnormality is reduction in the VEP amplitude. Let's look at some cases. This is a 19-year-old male who presented with blurred vision in the left eye for the past 3 weeks. There was slight imbalance whilst walking. There was no history of hypertension or diabetes. And this was his pattern VEP from the right eye. So as you can see, in all evoked potentials, you must take 2 readings to make sure that they are reproducible. In both the runs, his P100 latency was 104 to 105 milliseconds, which is within normal range. However, from the left eye, you can see that the P100 latency was 138 and 140 milliseconds. So the interpretation is that there was a delayed P100 latency and normal amplitude from the left eye, suggestive of left optic nerve demyelination. So what are the differential diagnoses of a delayed P100? Delayed or a prolonged P100 latency in pattern VEP. Commonly in children, it is seen in leukodystrophies, multiple sclerosis, Friedreich's ataxia, and drug toxicity, particularly with ethambutol. In case of ethambutol, initially the pattern VEP latency is prolonged and later the pattern VEP can be abolished. So the moment you find a delayed P100 when the child is on ethambutol, you must stop it or substitute it and not wait till his VEP is abolished. In MS, it is useful to detect silent optic nerve demyelination. So pattern VEP versus MRI. VEP gives information about the physiology and function of the anatomical pathway. However, it doesn't provide localizing information. Therefore, primarily it's used in assessing optic nerve function, especially prechiasmatic function. A normal pattern VEP practically excludes a prechiasmatic optic nerve lesion. MRI, in contrast, gives more accurate information about structural lesions and is highly accurate in localizing. So VEP is a useful test in prechiasmatic lesion, and in retrochiasmatic lesion, MRI is definitely more useful. Sometimes they are complementary. In infants and young children where visual fixation is not possible, pattern VEP is not feasible. So in such cases, flash VEP is performed. The child can be sedated. The same electrode placement as in pattern VER. And instead of the pattern VEP given through the cathode ray monitor, a high intensity flash is the eye, unilateral stimulation of the eye is done with a high intensity flash. It's a quick test and does not require the child's cooperation because it can be done under sedation. So this is how the flash VEP through LED goggles can be done. I usually don't use LED goggles. I use the typical handheld flash or a flash mounted on a stand, same kind of flash that you use during photic stimulation in EEG. So I do monoocular stimulation with that big high intensity white flash. A preserved flash VR confirms intact visual pathways, but it is not a sensitive test for foveal vision. The P latency is different in case of flash VEP. The upper limit of normal in children is 130 to 135 milliseconds, whereas the upper limit of normal in adults is 120 milliseconds. Flash VER and its role in perinatal asphyxia and cortical blindness due to bilateral occipital lobe lesions. Here, flash VER helps in assessing structural damage to the cortical visual areas. So this was a paper by Celestia et al. Which correlated VEP and the regional glucose metabolism using FDG PET. Those who had preserved flash VEP had some cerebral blood flow and some glucose uptake in area 17, that is the striate cortex. And patients who had absent flash VEP had no activity and no perfusion, no FDG glucose uptake in either occipital lobe. So here there is a direct correlation between the damage to the striate cortex and its correlation with the flash VEP. In case of visual dysfunction in infancy, one cannot figure out whether the visual dysfunction is because of optic nerve or retinal damage. Simultaneous flash VEP and ERG are useful for this. It allows objective assessment of function of the retina and the visual pathway. So how is this done? The recording is done using disc electrodes. So here you can see these are the ERG electrodes. The active electrodes are under the lower canthus of the eye, right and left. And this is the reference. And the flash VEP electrode attachment is the same, active over OZ and reference over FZ. Stimulus is monoocular. 1 Hertz flash is given to the eye. So when you give 1 Hertz flash to the eye, with the same flash, you record a flash ERG and a flash VEP. This is what it looks like. So this is the ERG response, the A wave and the B wave, and this is the flash VEP. And these are the normal latencies in children. One must always take 2 sets of readings to demonstrate reproducibility of the response. By which reproducibility, I mean that if you drag this response up, they should be superimposable. And this is what the report looks like. The comment will mention the flash VER and the flash ERG values, interpretation of the latency and the amplitude. So let's look at the electrodiagnosis of visual dysfunction in early infancy. In case of Leber's congenital amaurosis, the flash ERG is absent. The flash VEP is recordable but can be attenuated. That is, it can be small in amplitude or prolonged. In case of optic nerve hypoplasia, flash ERG is always normal. Only the flash VEP is absent. In case of Leber's hereditary optic neuropathy, AOCN, pattern VEP is abnormal. If the child doesn't have visual acuity to do a pattern VEP, then do a flash VEP. This should also be delayed or absent, and the flash ERG will always be normal. So in Leber's hereditary optic neuropathy and optic nerve hypoplasia, flash ERG should always be normal. The moment you get an abnormal flash ERG along with an abnormal flash VEP in an infant, you are probably looking at Leber's congenital amaurosis. What about neurodegenerative disorders? In early infantile Batten's disease, ERG is absent and VEP is also smaller absent. By the age of 4 years, both flash VEP and flash ERG are abolished. However, it's different in case of late infantile Batten's disease. Here, the ERG is small or absent, but the VEP here is not absent. You get giant amplitude of VEP in late infantile Batten's disease. So if you are suspecting Batten's disease, you should do a flash VEP ERG, and depending on your findings, you can make a clinical correlation as to what kind of disease it could be. This is another case. This is a 1-year-old boy being investigated for bilateral visual dysfunction. So this was his flash ERG and VEP from the right eye and flash VEP ERG from the left eye. As you can see, it's absent from the right eye. And although flash ERG is absent from the left eye, a very prolonged flash VR is recordable at a latency of 167. That is the P latency. So it's bilaterally abnormal, right more than left. And in the flicker ERG, 30 Hertz flicker is given to the eye. The flicker ERG was abolished from the right eye, but present from the left eye. So this was the conclusion that bilaterally absent flash ERG response is suggestive of bilateral retinal dysfunction. Though delayed, flash VR is present from both eyes, suggesting that integrity of visual pathway is preserved. This child had early infantile Batten's disease. There is some limitation of flash ERG. It does not give much information on rod dysfunction because the 1 Hertz flash ERG is predominantly a cone-mediated response. Similarly, 30 Hertz flicker ERG is purely a cone-mediated response. Therefore, if you do a flash ERG in a child, you cannot have much information on early rod dysfunction. Last case, this is a 6-year-old boy who had loss of visual acuity in both eyes after methotrexate chemotherapy for Burkitt's lymphoma. He noticed this after the second cycle. Now, only finger counting was present. So this was is pattern VEP. It was absent from both eyes. Now you can see some sort of waveform is seen here, but if you see run 1, run 2, and run 3, they are not superimposable. That's why you should not mark them. You can mark N75 and P100 only if they are reproducible in all 3 runs. Even here you can see some waveform is there, but that doesn't mean that the pattern VEP is present because they are not reproducible or superimposable. Now look at the flash VEP. You saw these 2 responses. They are both reproducible and fairly superimposable. So one can say that flash VER is present. The latency is 96 in this eye and 95 in the left eye. So flash VER latencies are normal from both eyes. Flash ERG was also done. This is also normal in latency from both eyes. So the interpretation of case 3 is that absent pattern VER suggestive of bilateral optic neuropathy, which was a toxicity from the methotrexate. Flash VER was present, suggesting integrity of the visual pathway is still preserved bilaterally, and normal flash ERG suggesting normal retinal function. This is another child, normal until the age of 9 months, had fever and coma, so query encephalitis with recurrent seizures from age 9 months, now presented with loss of vision in both eyes, and also gross motor delay post-encephalitis. You can see his flash VER. It's bilaterally absent. There's no reproducible response even in flash VER. So bilaterally absent flash VER compatible with cortical blindness and severe damage to the striate cortex. This is his MRI finding. So to conclude, pattern VEP is a sensitive test for pre-chiasmatic lesions. MRI is a more useful test for post-chiasmatic lesions. Flash VER is not a sensitive test for optic nerve and macular function. However, it does give information on the integrity of the visual pathway. Simultaneous flash VER and ERG can be performed easily in sedated children for evaluation of vision and visual dysfunction in children with neurodegenerative disorders. Flash ERG performed with 1 Hz flash and 30 Hz flicker gives us an idea only about the cone function, and early rod dysfunction cannot be judged. Thank you. I think we can take questions if there are any.
I don't see any question of this till now, but there is one where, yeah. So yes, what is the lower limit of amplitude of P100 in flash VEP?
In flash VEP?
Yeah.
5 microvolt.
Okay, and there is one for the previous one, which is like in severe hypoxic brain injury in neonates. SSEP is good for prognostication of brain injury. If N9 and 20 responses are not developed, then how should we assess it?
In neonates?
Yeah.
You can't use SSEP for prognostication in neonates.
Perfect. And there is one is amplitude measured peak to peak. I guess that they're asking for VEP.
For VEP, yes, it is N75 to P100 amplitude.
Yeah.
So usually that measurement is already there in the machine. Nowadays all the machines are computerized.
Right.
So that's the calculation it takes.
One more is how to do VEP in severe vision impaired person.
So as I said, if you want to do pattern VEP, the patient has to be able to see the pattern. The moment a patient has only finger counting or just light perception, the only test you can do is flash VEP. So that you will only interpret as prolonged, present or absent.
Right. One is, can we assess amplitude on flash VEP?
So we don't use flash VEP amplitude as much because the whole idea of flash VEP is just to see integrity of the visual pathway. It is a crude test.
Right.
You will only see whether it's present or absent, or whether it's grossly prolonged or present in the range of 130 to 140 milliseconds. Amplitude is useful only in pattern VEP. If the amplitude is grossly reduced in pattern VEP, that is a sign of axon loss optic neuropathy.
Right. And the last one is, can flash ERG be done with the same VEP apparatus?
Yeah, so obviously you cannot do flash ERG using LED goggles. You need the handheld or a pole mounted flash, the kind of flash you use in EEG in photic stimulation. And then once you apply all the electrodes, you should have the software to do it.
Right. So ultimately,
Your software should give
be
you a
exciting.
synchronized report of ERG VEP. So your channel 1 will be ERG and your channel 2 will be VEP.
And someone has written here, what are cognitive evoked potentials? So something not related.
Cognitive evoked potentials are event related potentials. So I shared it in my slide. I'll show it to you in the next one. N300 is a cognitive potential. So electrodes are applied over the scalp. You can stimulate and get a cognitive potential in various ways. In Jaslook, we used to do it by giving auditory sound to the patient. So a patient is given, continuous sound, and in that sound there will be one sound which will be skipped. So ta 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 ta. Like there will be a sequence, and in the sequence one note will be missed. When the patient recognizes that this note is missed, he will press a button. So like that, the test goes on and on. It takes about 1 hour. They are useful in patients who have cognitive dysfunction. So one study was done in Jaslook where it was used to find the N300 latency in children who were severely malnourished. So school children from our normal schools versus PEM children from municipal schools were studied, and it was found that P300 potential was abnormal or delayed in children who were severely malnourished. So the point of the study was to say that malnourished cognition is affected as a result of malnourishment. So one must address malnutrition so that these children's cognition does not suffer. And the second is P300 latency is prolonged in children who have early or subclinical cirrhosis. So that was a study we did with a gastroenterologist to see what is the cognitive dysfunction in NASH and subclinical cirrhotic patients. So anyway, that is not something you do in regular practice, and unless you have a study mounted, it's difficult to do a cognitive potential, but yes, you can do it. It's known as N300.
Yes, we can move on to the next. Yeah, because.
So now we have only 10 minutes left. I'll try and do BAEP quickly. Can you see my screen?
Yes, yes.
Yes.
Yeah.
Okay. So we call them brainstem auditory evoked responses or brainstem auditory evoked potentials. And in the US, they are known as ABR, auditory brainstem responses. Two names for the same test. So we are going to discuss a sensory evoked potential recorded from the scalp in response to auditory stimuli. We finished somatosensory stimulus and visual stimulus. The person who was asking cognitive potential is this event related potential. Auditory responses can be classified as electrocochleogram. So we go from distal to proximal. Starting with the cochlea, auditory response can be elicited in the form of an electrocochleogram ECG, BAEP, a mid latency auditory evoked potential, or a long latency auditory evoked potential. We are going to talk about BAEPs, which are five waveforms generated at the level of auditory nerve, that is the 8th cranial nerve, and brainstem in response to auditory stimuli. They are known as short latency auditory evoked potentials because they are elicited in the first 10 milliseconds from the onset of stimulation. The subsequent ones are known as mid latency or long latency auditory potentials. Let's look at the electrode placement. The active electrode is placed over the ear lobes, just in front of the mastoid bone. So A1 for the left side and A2 for the right side. The reference electrode is CZ. So this is common for right and left BAEP. So this will go in your channel 2, that is your anode. And because it is a common electrode, you have to connect the right and the left ear CZ electrodes using a jumper. A jumper is like a wire which goes into both the references of amplifier 1 and amplifier 2. The ground electrode can be placed over the forehead or over the neck. How is the recording done? An auditory stimulus is given unilaterally to the ear. Its intensity is usually 60 to 70 decibels above normal hearing level. So if the normal hearing level, let's say, is 25 to 30 decibel, intensity given should be between 95 to 105 decibel. It's given to the ipsilateral ear. The contralateral ear is masked with noise in the range of 30 to 40 decibels in order to prevent bone conduction. This stimulus is given at a rate of 10 hertz, and the stimulus comprises of a sound which is in the form of clicks. Now the clicks can be positive, negative, or alternate. So that is known as the polarity of the clicks. In our digital machines, you can choose what you want to give. We prefer alternate polarity because by giving alternate polarity, you suppress the responses from the cochlea. Responses from the cochlea are known as cochlear microphonics. They also arrive at a latency of about 1 millisecond. So if cochlear microphonics are present, you will not see a wave 1 very clearly. In order to see wave 1 clearly, you should use alternate polarity so that cochlear microphonics, commonly known as CM, are suppressed. Let's look at the generators of wave 1 and 2. Wave 1 is formed here. 1 minute. The distal part of the 8th nerve. It is preserved in all central nervous system abnormalities. It's prolonged or abolished in sensory neural deafness, obviously because it affects the 8th nerve. Wave 2 is the proximal part of the 8th nerve here. It is generated in the proximal part of the 8th nerve or the cochlear nucleus. It is poorly defined in neonates. Sometimes you don't see wave 2 at all. You just see a wave 1 and a wave 3 in neonates when you do a BERA. Wave 3. Now you can see now the response has crossed to the contralateral side. It is generated in the superior olivary nucleus in the lower pons through the trapezoid body. There are probably more than one generator for the wave 3. It is commonly disrupted in CP angle tumors. Wave 4 is generated in the lateral lemniscus. Remember we had the question in SSEP. Lateral lemniscus is the pathway of BAEP and not of SSEP. So wave 4 is generated in the lateral lemniscus and wave 5 is in the inferior colliculus in the midbrain. This is the most prominent waveform in BAEPs. So now you know the pathway of BAEPs. This is just to simplify for you. So this is the whole pathway of the brain. This is your wave 1, wave 2, wave 3, superior olivary nucleus, wave 4, lateral lemniscus, and wave 5, inferior colliculus. Now you do see that there is a response going over here. So this is the mid latency and the long latency auditory evoked response. We do not study it in our routine auditory evoked potentials, but it is elicited. You just need a separate machine and a separate software to see it. So this is how it goes. Eighth nerve, cochlear nucleus, superior olivary, lateral lemniscus, inferior colliculus. And these are the mid-latency auditory evoked potentials, which goes to the medial geniculate body and the auditory radiation up to the cortex. They are wave 6 and wave 7. So these are the parameters studied in BAP: absolute latency of the waveforms and interpeak latency intervals. That is the interval between wave 1 and 3 and wave 3 and 5. In terms of asymmetry between right and left, if the asymmetry of any waveform latency is greater than 0.5 millisecond between the left and the right ear, it's subnormal. These are the normal values. So ideally, you should have normative values for your lab. If not, this is available in Mishra and Kalita's textbook. This is what a normal BAP looks like. So as I said, wave 1 is here at a latency about 1.5 to 1.8 millisecond. The cochlear microphonics are usually elicited here. So if you use alternate clicks, cochlear microphonics are not seen. But if you use condensation or rarefaction clicks, they really contaminate this part of your BAEP and often waveform cannot be clearly seen. What are the clinical applications of BAP? In multiple sclerosis, 32 to 72% of patients show VEP and BAEP changes. The BAP abnormality is in the form of increased latency of 3 to 5 interpeak interval because of the demyelination and reduced amplitude of wave 1 to 5. What is found in acoustic neuroma? BAEP abnormality is seen in more than 90% of patients with a significant acoustic neuroma, where you see an increase in 1 to 3 interpeak latency interval. Let's look at a case for this. This is a 20-year-old male who presented with deafness in the right ear and blurring of vision in the right eye. This was his pattern BEP. As you can see in the right eye, P100 latency is 140 milliseconds, so grossly prolonged. Whereas in the left eye, P100 latency is 93 milliseconds, so normal. This was his BAEP. Wave 1, 2 are seen. Wave 3 is seen but delayed. Wave 4 and 5 are also delayed and not poorly formed if you compare it with the opposite side. As you can see here, the amplitude is 0.2 microvolt per division. So it's very small in amplitude. Whereas here you see a robust PAEP even at a sensitivity of 0.5 microvolt per division. So this is the interpretation. Prolonged right pattern VEP, normal left. In the BAP, waves 1 and 2 present. Wave 3 delayed. Hence, subsequent waveforms are also proportionately delayed. 1, 2, 3 interpeak latency interval prolonged. Waves 4 and 5 poorly formed. This man had a tumor in the right cerebellopontine angle, CP angle tumor. Now let's look at interpretation of interpeak latency intervals. Wave 1, 2, 3 IPL prolongation is more commonly seen due to tumor and inflammation or other disorders affecting the eighth nerve near the CP angle. Its normal value, upper limit of normal value of 1 to 3 interpeak latency is 2.5 milliseconds. In case of wave 3 to 5 interpeak latency interval, the upper limit of normal is 2.4 to 2.6 milliseconds. It measures conduction from lower pons to the midbrain. So lateral lemniscus up to the colliculus. What are the clinical applications of BAEP? In leukodystrophies, all BAEP latencies can be prolonged. However, the most important application of BAEP is to detect silent demyelinating lesion in the brainstem. Wave 3 and wave 5 latency can be prolonged in brainstem demyelination, and therefore 3 to 5 interpeak latency interval will also be prolonged. When the demyelination is severe, wave 4 and 5 can be abolished. Following up with BAEP also helps in monitoring response to treatment in demyelinating disorders, especially MS. What are the applications of BAEP in comatose patients? If the coma is due to a toxic or metabolic encephalopathy, usually there is no BAEP abnormality. But if the coma is due to a structural brainstem lesion, then changes in BAPs can be seen. In hypoxic brain damage, BAPs can be present and can be normal. Therefore, BAP is not a good test to predict outcome in brain hypoxia. In head injury, it's the other way around. If you find a severe BAP abnormality, you can give a poorer prognosis. But I think now there are many other modalities present, so we usually never use this modality to give prognostication in head injury. Maybe you can just use it in your answers if you get a question like this. Intraoperative monitoring of BAP is useful when there are posterior fossa procedures. For example, when there is microvascular decompression for trigeminal neuralgia or hemifacial spasm, then intraoperative monitoring of auditory evoked potential should be done. Lastly, we often use BERA, that is electric audiometry, for testing hearing threshold in infants, neonates, and young children who cannot undergo audiometry. This is because this test can be done under sedation. So let's look at the advantages of BAP. It is not affected by sedatives or anesthetic agents. It can be recorded even in hypothermic states. It is abolished only at a body temperature lower than 20 degrees C. So it's a good test to do for prognostication even when the patient has hypothermia. However, there are some limitations of BAP. If all waves are absent, sometimes you cannot determine the etiology. For example, you can have absence of all waves in severe hearing loss, that is sensory neural deafness, and you can have absent all waves even in a large acoustic neuroma. So the etiology cannot be gauged from an absent BAP. A normal BERA response virtually rules out an acoustic neuroma, but does not rule out intrinsic brainstem lesion or non-acoustic tumors of the CP angle, for example, meningioma. I will end my talk here. Thank you very much. I can take some questions.
I can see here. Can we do BERA for both ears simultaneously? So this is one I see.
No. How can you check hearing in both ears simultaneously?
And another one in newborn, how do you interpret? So this is a broad question here. In newborn, how do you interpret BERA? Yeah.
So first of all, BERA and BAEP are different tests. When you talk of BERA, you are looking at audiometry, means you are looking at hearing threshold. So yes, you can do BERA in newborns. The hearing threshold in newborns is also 25 to 30 decibel, and we commonly do it, especially high-risk newborns, those with hyperbilirubinemia. But if you talk of BAEPs, then the latency, let me go back to this slide. Latency of BAEP varies according to the age of the baby. So can you see this slide?
Yeah.
So these are the latencies you will elicit when the child is older, usually after the age of 6 months. So up to the age of 6 months, latency of wave 1 is prolonged in the range of 2.2 to 2.4 milliseconds also. So you must have normative data of BAEP values for neonates and children up to the age of 3 months. So you can say whether it is normal or abnormal, but you should have your normative data.
What is the difference between OAE and BAEP?
Autoacoustic emissions is a very crude test of hearing, whereas brainstem auditory evoked response gives you an idea of the pathway all the way from the eighth nerve up to the midbrain. And BERA gives you an idea about hearing. you can get a precise hearing threshold from BERA. Autoacoustic emission doesn't give you a precise hearing threshold in decibels. It's a screening test. Autoacoustic emission is a screening test.
Thank you so much, Dr. Margi Desai. We end the questions here. I hand over again to Dr. Rajesh Udani to sum up the 3 beautiful lectures, and I guess everyone is benefited immensely.
Yes, thank you, Margi. It's an excellent talk. It sort of went from the basics to the advanced, and I think it was very, told us about the usefulness of the different techniques and the use and the limitations. And I think after this, maybe more of us would be using the work potentials in your labs, so that because
Thank
otherwise,
you so much.
yeah, I think that was a very, very nice lecture. Thank you very much again, Margi.
Thank you very much. Thank you, Rachna, and thank you, Dr. Udani.
Thank you so much. Thank you.
Bye.
Bye-bye.
Thank you. Bye. Good night. Thank you so
Bye-bye.
much.
Good night.
Night. See you, Rachna.